Good evening, everyone. So I'm Dr. Pushkar. So I'm a second year DM neurology resident. And today's class, so I'll be mainly focusing on neuromyelitis optica, spectrum disorders, a little bit about anti-MOG and the variants of multiple sclerosis, and also the clinical features, presentation, the diagnostic implications, and the main parts of multiple sclerosis. The treatment of multiple sclerosis I'll be covering in the other classes. Okay, so this class will be mainly just like my other colleagues. So we will have some MCQs to have some basic framework. And I'll also be opening some polls. So after each MCQ, I want to see how everyone is answering. And after that, we can go into the discussion. Now coming to the first MCQ. So which of the following is not a core clinical characteristic of Devick's disease? So which of the following is not a core clinical characteristic of Devick's disease? So Devick's disease is the synonym for neuromyelitis optica, the older name for neuromyelitis optica. So which of the following is not a core clinical characteristic? Okay, so we'll wait for, I think 6 have answered. Maybe at least if 20 have answered, we will end the poll. Okay, most of you seem to be getting it right. I think there's a little confusion with narcolepsy, but all right, fine. Okay, I want more, at least 20 to participate. So at least by the end of the class, by the 30th MCQ, I hope most of you get all of it, most of it, at least 80 to 90 get the right answers. Okay, so that's great. So I think most of you are answering it right. Okay, so we'll conclude. So most of you have answered it right. More than 50 have answered it right. So which of the following is not a core clinical characteristic of neuromyelitis optica or Devick's disease? And the answer is neuromyotonia. So neuromyotonia is a separate neurological entity by itself, and it's out of the scope of discussion in this class. So let's go into what are the core. So obviously these three are core clinical characteristics, that is optic neuritis, narcolepsy, and area postrema. So these are the 6 important core clinical characteristics of neuromyelitis optica spectrum disorder. So as the name suggests, neuromyelitis, so transverse myelitis or acute myelitis is one core clinical feature, and optica, so optic neuritis. So these two you're surely going to remember. So the other 4, just you'll have to remember. So one is area postrema syndrome, and the next one is acute brainstem syndrome. And next is an acute diencephalic syndrome or a symptomatic narcolepsy. And then is a symptomatic cerebral syndrome. So this is very important because most of us are in the impression that NMOSD predominantly involves the optic nerves as well as the spinal cord. But actually that's not so. It even involves the cerebral structures also. So, and it has a predilection to involve the periependymal structures. So basically in NMO, it is because of antibodies to Aquaporin 4. So this Aquaporin 4 is actually heavily expressed in the periependymal structures. So that is the reason why you have involvement in these regions. So area postrema is a periependymal structure. So area postrema is nothing but the dorsal medulla. It's present in the dorsal medulla, and involvement usually presents with hiccups and vomiting. Okay, and many times we have actually seen cases where the only presentation has been only vomiting. Then eventually we get multiple referrals from MG saying that it's not. There is nothing from their side, and we take an MRI. There is a area postrema syndrome. There is a T2 flare hyperintensities in the dorsal medulla. So that is very important. Then an acute brainstem syndrome. So it can present with multiple cranial palsies, and acute diencephalic syndrome, which presents with narcolepsy. Okay, and also a symptomatic cerebral syndrome. But usually the cerebral involvement is not very prominent, but it is an important core clinical characteristics. So don't forget these 6: optic neuritis, acute myelitis, area postrema syndrome, acute brainstem syndrome, symptomatic narcolepsy or acute diencephalic syndrome, and a symptomatic cerebral syndrome. So these are the 6 core clinical characteristics of neuromyelitis optica. So let's go to question 2. So which of the following is the diagnostic criteria, the named diagnostic criteria that is used in the diagnosis of neuromyelitis optica? So this is a very important FAQ, especially for those who are preparing for EDSS neurology. It's been asked multiple times. I think it had come in EDSS also once. So great. Most of you seem to be answering it right. It's a very important repeat question. Okay. I think we'll end the poll. Right. So more than 50 have answered it right. Great. Okay. So the answer is Wingerchuk criteria. So Wingerchuk criteria is the named criteria that is used for neuromyelitis optica diagnosis. So anyone in the chat box, what is Neuri criteria, Pringle criteria, and Avaji criteria? Anyone wants to try? Okay, so those who are preparing for NESS DM Neuro, it's very important. Yeah, good. So Mohammed Chandil has answered correctly. Avaji's criteria is for, oops, sorry. Yeah, Avaji criteria is for MND. Great. What about Neuri criteria, guys? Neuri criteria and Pringle criteria? Okay, fine. So we'll continue. So actually, Neuri criteria is used for the diagnosis of frontotemporal dementia. It's used for the diagnosis of frontotemporal dementia. And Pringle criteria is used for the diagnosis of primary lateral sclerosis. So primary lateral sclerosis is a type of motor neuron disease which predominantly involves upper motor neurons. So Pringle criteria is used for primary lateral sclerosis, Neuri criteria for frontotemporal dementia, and Avaji criteria for MND. But don't forget the important one in this class, Wingerchuk criteria for neuromyelitis optica. Okay, so most of you have got it right. So that's great. Okay, so let's go to question number 3. So what percentage of patients with NMO will have anti-Aquaporin 4 positivity? The reason I put up this MCQ because this is a change from the earlier edition. The earlier edition had a different answer and the latest edition of Harrison has a different answer. And it's good that they've updated it. Actually, anti-Aquaporin 4 is a very, very sensitive as well as specific antibody for NMOSD. We can check it both in the serum as well as in the CSF. But this question is mainly serum Aquaporin 4. And it's great that many of you are trying as well as getting the right answer. Okay, I think there is a few have answered the answer from the old edition. That's all right. Okay, so we'll close the poll. We'll end the poll. Okay, fine. Okay, I think most of you have answered 80. That's close, but actually the answer is 90%. So, yes. So 90%. So 90% of patients with NMO will have a positive anti-Aquaporin 4 antibody. And very, very important is what is the technique that we use to detect this antibody. So this is also an important MCQ. We use the cell-based assay. We use the cell-based assay. Okay, there are certain labs that actually use ELISA, but please make sure whenever you're requesting, I think many of your people here might be sending your samples to NIMANS. So NIMANS actually does the cell-based assay, and that's very, very important. It's much more superior to ELISA. So yes, this is taken from Harrison. So anti-Aquaporin 4 antibodies are present in the sera of 90% of the patients. So in the earlier edition of Harrison's, actually that mentioned 70, but this is a change. Don't forget, it's actually 90%. It's highly specific as well as sensitive. All right. Okay, question number 4. We'll open the polls. So which of the following is false regarding the diagnosis of seronegative NMOSD? Okay, which of the following is false regarding the diagnosis of seronegative NMOSD as per the Wingerchuk's criteria? So is it exclusion of alternate diagnosis? Is it symptomatic narcolepsy plus an acute brainstem syndrome? Is it dissemination in space? Or is an optic neuritis for symptomatic cerebral syndrome? So again, this question is to highlight that the diagnostic criteria is different for a seropositive NMO as well as a seronegative NMO. Okay, so I think this comes a little bit rank deciding. I think a little difficult if you are getting it right. Okay, so most of you have actually ticked C. Okay, so let's go into the diagnostic criteria and then come back and answer this question. All right. Okay, so this is the diagnostic criteria for a patient with NMOSD who is Aquaporin 4 negative or has an unknown Aquaporin 4 IgG status. So the most important thing is the patient should have 2 core clinical characteristics, okay, that occur as a result of 1 or more clinical attacks, and of which at least one of the core clinical characteristics. So I think all of you remember what are the core clinical characteristics. It's optic neuritis, transverse myelitis, area postrema syndrome, symptomatic narcolepsy, a symptomatic cerebral syndrome, okay, and an acute brainstem syndrome. So these are the 6 core clinical characteristics. And for a seronegative NMOSD, we need 2 of these core clinical characteristics, of which one should be an optic neuritis, an acute myelitis, or an area postrema syndrome. So this is very, very important. At least one of this should be present if it is seronegative. There should be dissemination in space, and there should be fulfillment of additional MRI criteria, which I will come to right now. And the negative test for anti-Aquaporin 4 should be done using the best available technique. And the best available technique is cell-based assay. Okay, the most best detection method is a cell-based assay. And there should be exclusion of alternative diagnosis. So now let's go back to the MCQ. So exclusion of alternative diagnosis, yes, so this is true, it's not a false option. Symptomatic narcolepsy plus acute brainstem lesion. So this is the answer, because even though there are 2 core clinical criteria in this patient, it does not include optic neuritis or transverse myelitis or area postrema syndrome, because these, at least one of the 2 core clinical criteria should be an optic neuritis or a myelitis or a area postrema syndrome. So this is the answer, that is, it is a false option. And dissemination space, yes, that is true. And yes, optic neuritis plus asymptomatic cerebral syndrome. Yes, so optic neuritis is there. So at least this is there in one of the core clinical criteria, and a plus asymptomatic cerebral syndrome. Okay, so don't forget, this is there, this table is there in Harrison. It's very important. You could get an MCQ from here. And let's go into what are the additional MRI requirements. Okay, so basically, in additional MRI requirements for the optic nerve, so number 1, the patient should have an optic nerve lesion that is longitudinally extensive. Okay, so just like how you have a longitudinally extensive lesion in the spinal cord, you have a similar thing in the optic nerve. So it should involve more than 50% of the optic nerve length, or it should involve the optic chiasm. Okay, and remember, this additional MRI requirements is only for seronegative NMOSD, not for seropositive. If it's seropositive, it's totally different. It's very easy to make the diagnosis. I'll come to that. So additional MRI criteria, remember, more than 50% of the optic nerve or the optic chiasm should be involved, and the patient should have a longitudinally extensive transverse myelitis, that is involvement of 3 or more contiguous segments. Okay, and or the MRI is showing a focal spinal cord atrophy in patients who are having a history of acute myelitis. But just remember LETM. Okay, so a longitudinally extensive optic neuritis, a longitudinally extensive transverse myelitis, and a patient who is having area postrema syndrome, that is dorsal medulla involvement, and acute brainstem syndrome with periependymal brainstem lesion. So as I mentioned, NMOSD has a predilection to involve the periependymal brainstem lesion. So this is how we have to diagnose a case who is seronegative for Aquaporin 4 IgG, but has very strong clinical features of NMOSD. So how do you diagnose a patient who is seropositive? Okay, so a patient is seropositive for Aquaporin 4 IgG antibodies. Anyone, okay, any one core clinical characteristic is enough. Anyone, it could be a diencephalic syndrome, it could be a symptomatic cerebral syndrome, or it could be a area postrema syndrome, anything, nothing specific. And the positive testing for the Aquaporin 4 IgG should be done by a cell-based assay. Okay, don't forget this, cell-based assay, and exclusion of alternative diagnosis. So diagnosing a seropositive NMOSD is much more simple. You just need one core clinical characteristic and excluding alternative diagnosis and a cell-based assay positive antibody test. So let's go to the next question. So let's open the polls. Which of the following statements is false regarding neuromyelitis optica? So option number 1, it is more frequent in women compared to men. Progressive symptoms are common. The optic neuritis is bilateral and severe, and oligoclonal bands are uncommon. So I guess this is a little tough one. I think very few are getting it right, but that's all right. Okay, so we'll conclude. Okay, so most of you have answered D. Okay, so the question is, which of the following is false? So oligoclonal bands uncommon actually is true. Okay, so oligoclonal bands are actually present in less than 20% of patients with NMOSD. Okay, so most of you answered D. Okay, but actually no, oligoclonal bands are actually uncommon in NMOSD. It's more seen in multiple sclerosis. So let's analyze option 3. Optic neuritis is bilateral and severe. Yes, that is true. And progressive symptoms are common. Okay, so remember that in NMOSD, it is more of a relapsing and remitting illness. It is a disease that relapses, remits, relapse, and remits. It's very unusual for an NMOSD to have progressive symptoms. Progressive symptoms is more in favor of multiple sclerosis. Okay, so multiple sclerosis is more for progressive symptoms. So this is actually the answer. This is the false statement. And it is more frequent in women compared to men. So yes, it is true of any other demyelinating or autoimmune illness. So it is much more common in women. So this question is to highlight the demographic features of NMOSD. So females more than males, just like in multiple sclerosis. The onset is little more later than multiple sclerosis. So usually MS, if you take multiple sclerosis, the onset is from 20 to 40 years. Okay, usually Relapsing remitting MS usually has a 20 to 40 years onset. But actually, if you take a primary progressive MS, actually it is 40 years. But if you take MS in the whole sense, usually MS has a younger age of onset, but NMOSD is usually a disease of adulthood, usually in 40 years of age. And yes, the optic neuritis is bilateral and severe, as discussed earlier, and the myelitis is very severe, longitudinally extensive, that it involves 3 or more vertebral segments, contiguous vertebral segments. And very important, that is the one in our question, unlike in multiple sclerosis, progressive symptoms is not a feature of NMO. Progressive features is a feature of multiple sclerosis. And the CSF exam in neuromyelitis optica, oligoclonal bands is an uncommon feature. It is present only in less than 20% of patients. And we can have some cells, okay, that is pleocytosis. So you can have some cells in NMOSD, and usually these cells are neutrophils. Usually these cells are neutrophils and eosinophils. Okay. So to conclude, OCBs are uncommon and progressive symptoms are uncommon, and rest of the demographic data as we have discussed. Okay, so we'll go to question number 6. So what is the classical enhancement pattern of the cerebral lesions, okay, of the cerebral lesions in the MRI brain in Devick's disease? So Devick's disease is nothing but I think most of you already know, it's a synonym for, okay, good. We have many people giving the right answer. That's great. It's given only in very passing mention in Harrison, but it's important since it's a named imaging feature. So it's very likely to be an MCQ. Great. Most of you are giving the right answer. So cerebral lesions enhancement pattern. Okay, we'll conclude the polls. Good. 40% of you have given the right answer, and it is cloud-like lesions. Okay, it is cloud-like lesions. So anyone in the chat box wants to answer which demyelinating illness you get a concentric pattern? Anyone wants to try? Yeah, world and MS. Okay, that's new, but I don't think so. Anyone? What about concentric pattern? Anyone wants to try? Okay, fine. So I'll give the answer in this. So actually, concentric pattern, you get it in Balo's concentric sclerosis. Okay, you get it in Balo's concentric sclerosis, as the name suggests. But so don't forget, cloud-like lesions. Okay, the enhancement pattern is cloud-like lesions. So this is as mentioned in Harrison. So large MR lesions in NMOSD in the cerebral hemisphere, even though they are asymptomatic most of the times, they can have a cloud-like appearance or enhancement pattern. But however, unlike in multiple sclerosis, the cerebral lesions are not very destructive. It's usually the optic nerve lesions and the spinal cord lesions which are destructive. So this is from an article from Ito S. et al. So anyone, any idea what sequence of MRI this is? Okay, so actually this is MRI brain, axial view, and this is a T1 weighted image, post-gadolinium contrast. Okay, so here we can see this is the classically described cloud-like enhancement pattern in Ito's article, which was published in 2009. So this is the cloud-like pattern we see in NMOSD. So just don't forget that name. I think it's very unlikely you'll get an image question for as like this, but I just wanted to show out of interest. Question number 7. So what percentage of NMO patients will have an associative connective tissue disorder? And the reason for me putting this MCQ is to highlight the importance of the association of NMO with other connective tissue disorders and how it is very important to screen for other connective tissue disorders in a patient who has been diagnosed with NMOSD. Yeah, so Sehar just answered MS Balo. Sorry, I just saw your chat. Okay, most of you giving a close answer. Okay, but anyway, it's a factual question. It's an all or none phenomenon. So either you know it or you don't. So this is as taken from Harrison. But the take-home point is NMOSD, always look for a connective tissue disorder. So I think this might be a rank deciding question if it comes. So only 24 have given the right answer. We'll conclude the polls. We'll end the poll. Yeah, great. So most of you have marked C. Okay, that's a close answer. Okay, I agree it's a factual question. So just a minute, please. Okay. Yes, so the actually answer is 40%. Okay, so 40% of NMO patients will have an associated connective tissue disorder. And the reason why I put up this MCQ is because whenever you have a diagnosed NMOSD, please screen for other connective tissue disorders. It's very, very important. So this is as taken verbatim from Harrison. So 40% of patients will have some sort of systemic autoimmunity, and this could be in the form of SLE, a Sjogren syndrome, an ANCA vasculitis, or even myasthenia gravis, autoimmune thyroiditis, or even mixed connective tissue disorders. So don't forget this 40, and don't forget the fact of systemic autoimmunity association with NMO. Okay, so question number 8. So little tricky one. So which of the following is not FDA approved for the treatment of NMO? So which of the following is not FDA approved for the treatment of NMO? Okay, so this MCQ, actually, I remember attending in AIMS 2021, and I very confidently went and marked the wrong answer, and I thought it was right. Only after going back home, I realized I was wrong. So I think most of the audience here are MD General Medicine PGs. So I think most of you would have managed transverse myelitis and NMO. And I think most of us are have surely given rituximab for these cases. And even the institute where I am doing my residency, we do give rituximab. Okay, so I'm giving out the answer. So actually, interestingly, the drug that we actually commonly use for NMOSD is sadly not FDA approved. Okay, so it's not FDA approved. And so after giving my AIMS 2021 exam, I realized that after going home and checking the repeats, going and checking the answers, I realized I had given the wrong answer. So I think, okay, so most of you have marked eculizumab, but actually eculizumab was the first drug that was FDA approved for NMOSD. So we'll conclude this poll. Okay, so most of you have given the answer as NMOSD and rituximab. Okay, so I don't blame those who have ticked rituximab, because most of us actually use rituximab for the treatment of NMOSD. So which of the following is not FDA approved? Yes. So rituximab is not FDA approved for the treatment of NMO, but these other three, that is eculizumab, inebilizumab, and satralizumab, all three are FDA approved for the treatment of NMO. Eculizumab is a terminal complement inhibitor. It's a terminal complement inhibitor. Inebilizumab is a anti-CD19 agent. Okay, so any idea rituximab, anyone? Yes, it is a CD20 inhibitor. Okay, so rituximab is a CD20 inhibitor, whereas inebilizumab is a anti-CD19 inhibitor, and satralizumab is anti-interleukin 6 receptor monoclonal antibody. Okay, so don't forget these three: eculizumab, inebilizumab, and satralizumab. So these are the three FDA approved drugs for NMOSD. And don't forget the mechanism of action: terminal complement inhibitor for eculizumab, CD19, anti-CD19 for inebilizumab, and also interleukin 6 receptor blocker for satralizumab. Don't forget this receptor blocker. Okay, so sometimes they might give an MCQ: what is the mechanism of action of satralizumab? And it will be IL-6, and then you will have IL-6R. So don't forget, it's an interleukin 6 receptor blocker, not a molecule blocker. All right, fine. So this is a table from Harrison. So you can see eculizumab has a risk reduction of relapse of 94% in patients who are seropositive for. Most of the studies are actually for seropositive Aquaporin 4. But don't forget eculizumab, satralizumab, and inebilizumab is not FDA approved. Okay, this is mentioned in this table. Actually, it is used for graft versus host disease. Okay, it has nothing to do with NMOSD. I don't know why they mentioned it here. But actually, inebilizumab in olimumab is used for graft versus host disease, but eculizumab, satralizumab, and inebilizumab are FDA approved for NMOSD. Okay, so very important question. Let's open the polls. So which of the following vaccines should be given before giving eculizumab? Okay, this is very important, probably a prospective MCQ also. Okay, more people participating. Great. So many. Okay, so I think it's good that most of you know this. That's great. Wow, so many people have answered and also answered correctly. That's great. For those who want to try, it's very important to remember most of the exams are MCQ based. So it's important to prepare that way also. It's nothing wrong if you get it. No issue if you get it wrong. It's anonymous. So please try. Great. Finally, 50% have participated. First MCQ. Okay, we'll conclude the polls. Okay, that's great, guys. I think most of you have given the right answer. So the answer is, oops, sorry. Okay, so the answer is meningococcal vaccine. So that's very, very important. Okay, so because this highlights the fact that the terminal complement system is very, very important in anti-meningococcal immunity. Okay, so I think most of you might have read this in microbiology. So not only meningococcal vaccine, it is also very important to have a low threshold to diagnose meningococcal sepsis or meningococcal meningitis in a patient who is receiving eculizumab. Okay, so that is very, very important. Don't forget, eculizumab, meningococcal sepsis. Okay, and not only meningococcal sepsis, the meningococcal sepsis in patients who are eculizumab treated is usually life-threatening and fatal. And patients should receive the meningococcal vaccines at least 2 weeks prior to administering the first dose. And remember, vaccinating the patient for meningococcemia, for meningococcal infection, does not protect the patient. Patient is still at high risk for developing meningococcal sepsis. So always remember, any patient who's receiving eculizumab either from nephrology or from neurology have a very low threshold for diagnosing meningococcal sepsis or meningococcemia in these patients. So that's a take-home point of this MCQ. So we'll go to the next one. Okay, so this is a all-or-none question. Either you know it or don't. It's a factual question. Let's open the polls. What is the route of administration of satralizumab? Wow, great. Many way of getting it right. So route of administration of satralizumab. So if this question is put up, I think you're sure it's obvious it's not IV, because most of the other drugs we give for NMOSD are actually IV. So rituximab, ineblizumab, and even eculizumab is given IV. So this is the odd one out. So that's why I put this MCQ. And it's great that most of you are answering right. So more than 50 have participated. We'll conclude the polls. We'll conclude. Yeah, great. So 63% of you have given the right answer. So that's great. So the actual answer is subcutaneous. Okay. Guys, easy way to remember it. Satralizumab starts with S. S for subcutaneous. Okay. Just a shortcut. Okay. So the important point is most of the medications we give for NMOSD, that is either off-label as rituximab or on-label as eculizumab or ineblizumab, is given as IV scheduling, whereas satralizumab is the only one that is given subcutaneous route. And remember, satralizumab is a monoclonal antibody against the interleukin-6 receptor. Okay, so let's go into that. The answer is subcutaneous. It is a monoclonal antibody that binds to the interleukin-6 receptor. Okay, I am again emphasizing this because I don't want you to mark interleukin-6 in the exam. I wanted to mark interleukin-6 receptor. Okay, great. Okay, and the dosing schedule, we give it as 120 milligrams by subcutaneous route at week 0, week 2, and week 4. And after that, monthly maintenance dose at 120 milligrams every 1 month. Okay, so satralizumab, subcutaneous interleukin-6 receptor blocker, and 120 mg, 0, 2, and 4th week. After that, it's given monthly. Just remember these points. Okay, so let's go to question 11. I think I've already mentioned this earlier. So let's open the polls. So what is the mechanism of action of ineblizumab? What's the mechanism of action of ineblizumab? Okay. So most of you are paying attention because most of you have given the right answer. So that's great. I'm very happy. Great. Almost all of you. Okay, great, guys. Most of you answered right. I'll end the poll. Okay, so 88% of you have given the right answer. So it is anti-CD19. Don't remember. So which one is anti-CD20? It is rituximab. But remember, rituximab is off-label. Okay, I'm emphasizing this point. Rituximab is not FDA approved, but rituximab is anti-CD20. Okay, that's why. And anti-CD19 is ineblizumab. Okay, so don't forget this. Okay, so as I mentioned earlier, I'm not going to repeat again. Dosing, yes. Okay, it is given IV. Okay, just like rituximab. So rituximab usually we give around 2 grams. It depends on center to center, but usually we give around 1 to 2 grams. Initially 1 dose, and then 2 weeks later we give the second dose, followed by 6 monthly. This is somewhat similar to that. So basically we give 300 milligrams as an IV infusion. 2 weeks later we give another 300 milligrams, and after this we give 300 milligram every 6 months. Okay, somewhat similar to the rituximab dosing pattern. Okay, so question number 12. This is a little bit out of Harrison's. Okay, this is for those who are preparing for EDSS neurology. So which will open the polls? Which part of the spinal cord is peculiarly involved in MOGAD? Okay, so usually if you take multiple sclerosis and NMOSD, so MOGAD, for those, I'm sorry for using an abbreviation, MOGAD is actually MOG antibody associated disease. Okay, so basically I'm sure all of you know about anti-MOG. So the disease spectrum of anti-MOG is known as MOGAD, that is MOG associated disease, and it has a very peculiar location or a predilection to involve. Okay, so if you take multiple sclerosis and NMOSD, they tend to involve the cervical cord. Okay, usually it has a predilection to involve the cervicothoracic cord in multiple sclerosis and NMOSD. But in MOG, it's not that it shouldn't involve the cervical cord, but it has a very peculiar preference for one part of the spinal cord. Okay. it's good. Most of you have given the right answer. Okay, we'll conclude the polls. So it's great. Most of you are giving the right answer. More than 50 have given the correct answer. It is actually conus medullaris. Okay. So MOG has a predilection to involve the conus medullaris. Okay. So this is given in short in Harrison. Okay. But I just wanted to open another article I had taken from RSNA, which is published in 2019. So it's a very beautiful diagram which summarizes the optic nerve, spinal cord, and the cerebral involvement for NMOSD, MOG, and multiple sclerosis. So I'll just rush through because this is important for those who are going to give NESS. So I'll not take much of just 5 minutes. So if you look for NMOSD, usually the involvement is posterior. Okay, so in NMOSD, there's a predilection for involvement of the posterior part of the optic pathway and very, very specific involvement of the optic chiasm. Okay, because actually the optic chiasm is a periependymal structure, and as I mentioned earlier, Aquaporin 4 is heavily expressed in the periependymal structures. So it is involving the optic chiasm, and also it is longitudinally extensive, that it involves more than 50% of the optic nerve length. So let's go into MOG. So MOG also is a very peculiar feature. In contrast to NMOSD, it likes to involve the anterior part of the optic pathway. Okay, it has predilection to involve the anterior part of the optic pathway, and it also tends to involve the optic nerve head. So it causes papillitis. Okay, so many a times actually we have seen cases in the neurology OPD. Actually, they present bilateral papilledema and some vague headache, and we think it's IEH. But however, the visual acuity will be out of proportion because usually papilledema will not cause a decrease in the visual acuity. And many of those times, these patients actually end up to be a MOGAD. Okay, because it has a predilection to involve the optic nerve head. So it will present just like papilledema, but we don't call it papilledema here. We call it papillitis. So anti-MOG, remember, anterior part of the optic pathway and predilection to involve the optic nerve head causing papillitis. Multiple sclerosis, classically, it is very short. It is less than 50%, and it is retrobulbar. Okay, it is retrobulbar. It tends to involve the middle part. Okay, or basically behind the optic nerve head. Okay, so important things, multiple sclerosis is unilateral, less than 50%, and it involves the middle part or retrobulbar part of the optic nerve. MOG is, one more thing I forgot to tell, it is bilateral. Okay, so MOG and NMO both are bilateral. So MOG is bilateral, anterior predilection, and it causes optic nerve inflammation or papillitis. And NMOSD is also bilateral, and it is extensive. It is more than 50% of the optic nerve, and it has a predilection for the posterior part of the optic pathway, that is the optic chiasm. So now let's go to the spinal cord. So first for NMOSD, it tends to involve the cervicothoracic cord. Okay, it tends to involve the cervicothoracic cord, and very, very important, involves both the white matter as well as the gray matter. Okay, so this is, you can see an axial section of the spinal cord. It tends to involve both the white matter as well as the gray matter of the spinal cord. So let's go to MOG. So very, very important. This is the question we had discussed. So it has a predilection to involve the conus. So MOG has a very, very specific or peculiar involvement. It likes to involve the conus, and just like NMO, it can cause both white matter and gray matter involvement in the spinal cord. When you take MS, this also has a predilection for the cervicothoracic cord, but usually the lesions are somewhat patchy or shorty in nature. Okay, you can see it's very patchy, very, very patchy, and it predominantly involves the white matter rather than the gray matter. And if you take the cerebral lesions for NMOSD, you can see it involves the periependymal structures, the area postrema, the brainstem, periependymal brainstem, and also areas in the cerebrum which is surrounding this. Whereas MOG has a very peculiar predilection. It likes two areas. So one is actually the basal ganglia structures. Okay, it has a predilection for the deep gray matter structures. Okay, the thalamus, the putamen, and the caudate. Okay, so it likes this, and it also likes the, anyone knows what this is? Anyone wants to try in the chat box? This is actually the cerebellar peduncles. This is actually the cerebellar peduncles. Okay, so MOG likes the deep gray matter, that is the thalamus, basal ganglia structures, and it also has a predilection for the cerebellar peduncles. Now coming to MS, I think all of you know periventricular lesions and infratentorial lesions. Okay, and juxtacortical lesions. So this is the juxtacortical lesion. These are periventricular lesions, and this is infratentorial lesions. Okay, so I think if the exam is going, NEET is predominantly Harrison based. I don't think they're going to test your very depth knowledge in this, but for those giving NESS, don't forget this slide. It's very important. Okay, so let's go to question 13. So which of the following is false regarding anti-GFAP encephalitis? So let's open the polls. So this is a new addition to the latest edition of Harrison, and it was, I think, first described, I think, in 2016, if I'm if I'm not wrong. And it's very rare, very, very rare. And I think possibly, I think I've seen one case till now in residency. It's very, very rare. And so what's the false statement? We'll go into the facts later. Okay, so most of you giving the right answer. Okay, we'll conclude for want of time. Fine, great. Most of you given the right answer. And sensibly so. So what is the false option? Not glucocorticoid. It is very much glucocorticoid responsive. Okay, so the other statements are true. Yes. So GFAP encephalitis usually presents, always remember, it in contrast to the its other counterparts of demyelinating illness, it presents with a meningoencephalitis picture. Then it will present as an optic neuritis. Then it presents as a transverse myelitis. So optic neuritis, transverse myelitis with meningoencephalitis. So patient will have altered sensorium, seizures, non-convulsive status. So this is the usual presentation. It has a very stormy presentation and a very guarded prognosis too, and very classical serpiginous pattern of enhancement. And it has neuroimaging features similar to neurosarcoidosis. So this is the true statements. So the answer is this. It is very much glucocorticoid responsive. So this is the false statement. So let's go into the facts. So as I mentioned earlier, meningoencephalitis, transverse myelitis, and optic neuritis. And very classically, just remember these words: periventricular radial orientation with a periependymal pattern of enhancement or MRA involvement, and it has a serpiginous pattern. Okay, it has a serpiginous pattern. So just remember these words: periventricular, radial, periependymal, and serpiginous pattern. And the enhancement patterns and neuroimaging patterns are very, very similar to neurosarcoidosis. So these are the facts that you should note in GFAP encephalitis. So it's a totally factual question. So I hope you remember these. Yes, and other important points I wanted to mention is antibodies are checked both in CSF and serum, like any other autoimmune or demyelinating illness. And 25% of cases will have an ovarian teratoma. 25% will have an ovarian teratoma. So chat box, what is the other autoimmune disease that is associated with ovarian teratoma? Anyone wants to try? What are the neurological disease or what are the neurological autoimmune diseases associated, very strongly associated with ovarian teratoma? Anyone wants to try? No one? Okay, fine. Then I'll give the answer. So the other neurological disease is actually, is anti-NMDR receptor encephalitis. Okay, so this is the other neurological disease that is associated with ovarian teratoma. Just don't forget, it's also associated with GFAP encephalitis. Not as strongly so, but it is. And the important part of our question, it is very much glucocorticoid responsive. So we'll go to the next question. So question number 14. So what is the diagnosis? So this is the image. So let's open the poll. Okay, so we'll open the poll. So this is an MRI brain. It is an axial view. It is a T1 weighted image, and it is also post-gadolinium contrast image. So most of the contrast, whenever you see a contrast, it's always T1 weighted. We look at contrast in T1 weighted images only. So here we can see alternating areas of hyperintensity and hypointensity and hyperintensity in multiple areas. So how are the polls going? Great. So most of you are giving the right answer. I'll conclude the poll since more than 50% have participated. Okay, so the answer is Balo's concentric sclerosis. So that is the answer. So you can see, as the name suggests, we have alternating areas of hyperintensity, and so this is hyperintensity, then you have a hypointensity. So it has a concentric appearance or a concentric pattern of demyelination. This is because of alternating spheres of demyelination and remyelination. And this is a classic neuroimaging feature of Balo's concentric sclerosis, which is a variant of you can take it as a variant of multiple sclerosis or another CNS demyelinating illness. The classical feature is the concentric grin enhancement, and this is because of alternating spheres of demyelination and remyelination, and it is a fulminant demyelinating syndrome with a very guarded neurological prognosis. So this is another fulminating demyelinating syndrome. Anyone who wants to try? So this is an MRI brain. It's an axial view. And it is a T2 flare sequence. Okay, it's a flare sequence. So we can see there are areas of hyperintensity, okay, which is predominantly juxtacortical. There's areas of hyperintensities with underlying area of hypointensities. And this is also an MRI brain. This is also axial. But however, this is a T1 weighted image with post-gadolinium contrast. So we can see the same area that is hyperintense on T2 weighted image, on FLAIR images, is peripherally enhancing. So let's open the chat box. We'll see if anyone's got it right. Excellent. Okay, so most of you have got it right. This is the neuroimaging features of Marburg variant. Okay, this is the neuroimaging features of Marburg variant of MS. So this is also known as tumefactive MS. Okay, sometimes it is very difficult to diagnose. Usually the patients will present as a intracranial space occupying lesion. So the usual presentation is very stormy. Patient presents with headache, LR palsy, papilledema, and the patient is usually very sick. Initially it turns you off. You will not get very difficult to get the diagnosis. And most of the times we actually have to do a brain biopsy to establish the fact that it's demyelination. And brain biopsy in this case is very, very important because the treatment itself will change. Okay, it is not resection. We'll have to do a brain biopsy. And if it turns out to be a Marburg variant, we'll have to treat the patient with IV steroids and a plasma exchange and whatnot. Okay. And since I spoke about IVIG and plasma exchange and IV steroids, don't forget the acute management for NMOSD as well as anti-MOG is actually pulse IV steroid or plasma exchange. There is no role of intravenous immunoglobulin in patients with NMO or MOG. Okay. Since I mentioned that, I just got reminded of that. Okay. So let's go to question 15. So we'll open the polls. Which of the following is the most common initial symptom of multiple sclerosis? So I have framed this question based on the first tabular column in the multiple sclerosis chapter. So, okay, already all of you are getting right. Okay, but anyway, we'll keep it open for others. Okay, I'm very happy most of you got Marburg right. And also most of you are getting this right. Okay, guys, we'll conclude. Okay, for want of time, we'll conclude. Most of you have got it right. That's nice. Okay, so answer is, okay, most of us who are naive to this chapter in Harrison, most of us might have marked optic neuritis, but actually the answer is sensory symptoms. Okay, but this is just a factual MCQ. I'm just basing it, this is based on a table in Harrison. So if you can see sensory symptoms or sensory loss is the initial presentation in 37% of patients of multiple sclerosis, whereas optic neuritis is 36. So just 1% difference. Okay, so that's why I've framed it as an MCQ. So just don't forget, it is sensory symptoms, which is the most common symptom, followed by optic neuritis. Okay, so let's go to question number 16. So we're already halfway through. Yes, so let's open the polls. So which of the following is not a feature of trigeminal neuralgia due to multiple sclerosis? So this is an indirect question. So basically I'm asking you, which of the following is not a clinical feature of a secondary trigeminal neuralgia? Okay, so we have primary trigeminal neuralgias and secondary trigeminal neuralgias, and they have totally different demographics, totally different clinical presentations and treatment also. Yeah, good. Many of you are answering it right. Okay. Maybe you're getting it right in the chat box too. Okay, so we'll conclude this. Great. So more than 50% of you have got it right. So let's analyze this MCQ. Okay, so which of the following, so let's see which of the following is not a feature of multiple sclerosis trigeminal neuralgia or a secondary trigeminal neuralgia. So onset before, so when you take a patient with multiple sclerosis plus a trigeminal neuralgia, so usually the age of onset is less than 50 years. Okay. Usually it's less than 50 years and the symptoms are usually bilateral and the patients have associated sensory loss, and number 4, presence of non-paroxysmal symptoms. So these are the features of a trigeminal neuralgia because of a demyelinating illness. So younger age of onset, bilateral symptoms, presence of objective sensory loss and non-paroxysmal symptoms. So just invert this. This is the features. So the opposite of this will be the features of a primary trigeminal neuralgia. So if you take a primary trigeminal neuralgia, usually it's a disease of older age. It's usually a elderly female patient, somewhere around 60s or in the 70s. It's most of the time unilateral. And when you do a clinical exam, there is no sensory loss if it's a primary trigeminal neuralgia. And the symptoms are paroxysmal, okay, lancinating and paroxysmal in a primary trigeminal neuralgia. But in a secondary trigeminal neuralgia, because of multiple sclerosis, it is non-paroxysmal. In addition to paroxysmal pain, you can have non-paroxysmal. So the answer is 2. So this is the this is the false answer. That is, it is the answer. So there is no objective sensory loss. No, in multiple sclerosis, we will have sensory loss if it's causing trigeminal neuralgia. So Trigeminal neuralgia and multiple sclerosis, just to revise, onset less than 50 years, that is young age or onset. Bilateral symptoms, very, very important. Presence of objective sensor loss and the presence of non-paroxysmal pain in addition to the paroxysmal pain. So great, we'll go to the next MCQ. So let's open the poll. So we have a 40-year-old female patient presenting to the neurology OPD for review. She is a known case of multiple sclerosis and she's on interferon therapy. And she complains of blurring of vision after a hot shower. So what is this known as? I'm sure most of you are going to get it right. Okay, but I just want to bring it out again so you can revise. Great. And as I mentioned, all of you have got it right. Not even one wrong answer. Okay. So since all of you have got it right, I want you, the toppers in the chat box, to tell me what is full-fledged phenomenon. Okay, or just the gist of it. Cox phenomenon and Bell's phenomenon are just red herrings. I just kept it as decoy options. Forget about those. Uttov's phenomenon is the right answer. Okay, so we'll end the poll. It's great. Most of you have got it right. Does anyone want to tell me in the chat box what is full-fledged phenomenon? So the highlight of this point is in multiple sclerosis or any other demyelinating illness, it is temperature sensitive. Okay, so sometimes these patients come with pseudo exacerbations. So basically, they're a case of MS with already multiple lesions in the MRI, and they get a fever or they are exposed to some sort of warm climate. So what this does is already their saltatory conduction is impaired because of conduction block and demyelination. So actually, temperature slows the nerve conduction velocity even more. So it brings out the pre-existing symptoms in these patients. So a patient who has already had an optic neuritis or something, when they're exposed to higher ambient temperatures, there can be a transient worsening or a re-emerging of the old neurological symptoms. So this is what is known as Uttov's phenomenon. So I'll open the chat box to see about full. Yeah, great. So Sapna Mittal has answered the right answer. So Pulfrich phenomenon is actually an alternation in the depth perception. So basically in Pulfrich phenomenon, what happens is, so the optic nerve the impulses are going very slow to the visual cortex. So because of this, there is some issue with the depth perception. Okay. So patients don't perceive the depth or the distance between them and the object. So what is actually viewed as two-dimensional may actually appear as three-dimensional. So let's take an example of a pendulum. Okay. So normally when we see a pendulum, we perceive the movements in a two-dimensional view. But in a patient who's having an optic neuritis and multiple sclerosis, this Pulfrich phenomenon, what happens is this depth perception or the three-dimensional or two-dimensional perception is totally distorted. And the patient may actually visualize the pendulum going in a circular pattern. Okay. And this is just nice to know. Okay. So just remember, Pulfrich phenomenon, the keyword is depth perception, and Uttov's phenomenon is actually heat sensitivity. Okay. So as we discussed, Uttov's phenomenon, and it's because of, and the underlying reason for this transient worsening is because of a transient conduction block because of increased ambient temperature. Okay, great. We'll go to question number 18. So which of the following is false regarding the paroxysmal symptoms in patients with multiple sclerosis? Okay, we'll open the poll. So we have also a set of ancillary or paroxysmal symptoms in patients with multiple sclerosis. Okay, so this could be a paroxysmal vertigo, a paroxysmal ataxia, something like an extensor or tonic spasms. So we have a wide array of paroxysmal symptoms in multiple sclerosis. And the reason for this paroxysmal symptoms is actually usually at the edge of the demyelination, there is some sort of abnormal depolarization. So that is the usual reason. So which of the following is false? Okay, that's great. Most of you are giving the right answer. Oh, almost more than 75 are giving the right answer. Yeah, Sehad Singh has asked Pulfrich occurs in which disease? Actually, it occurs same in multiple sclerosis with optic neuritis only. Both Pulfrich and Uttov's happens in optic neuritis. Okay. Okay, we'll conclude the poll. Most of 80% of you have got it right. Okay, that's great. And we'll continue the class. Yeah. So we'll analyze this MCQ. So paroxysmal symptoms in multiple sclerosis. Sorry for the spelling mistake. Okay, so it lasts for a few seconds. Yes. Low frequency, no. Actually, it is high frequency. Okay, it happens multiple times per day. Okay, so paroxysmal symptoms in multiple sclerosis is high frequency. Yes, the patient has an intact consciousness as well as a normal EEG. Okay, so sometimes it can be confused with an epilepsy or seizures. So the patient's consciousness is intact and EEG is normal. And an example is Lermit symptoms. Yes, Lermit symptom is an example of paroxysmal symptoms. So let's rush through the facts. So paroxysmal symptoms in MS, they are brief duration, usually a few seconds to a few minutes. very high frequency. They occur around 5 to 40 times per day. And however, the patient's consciousness is totally normal. There is no change in the background EEG, and it's usually self-limiting. It usually resolves within a few months. And important examples, okay, so this could be a possible MCQ: Lermit symptom, tonic spasms, paroxysmal ataxia, paroxysmal dysarthria, and as well as paroxysmal sensory disturbances. So, and just an interesting question for those who are interested, you can try answering this chat box. So I think most of you know what Lermit symptom is. So basically, I'm sure you know that. I want those in the chat box can tell me what is inverse Lermits and what is reverse Lermits. Okay. Or maybe you can send me the messages. I'm on Instagram, same name. Maybe you can text me after the class because of want of time. So we'll go to the next MCQ. Okay, so question number 19. So which of the following is the most common type of multiple sclerosis? Okay, it's a very easy question. I've just brought up this MCQ so we can discuss the different types. Is it relapsing MS? Is it primary progressive MS? Is it benign MS? Or is it a secondary progressive MS? Okay. So most of you are getting right. Okay, a lot of participants. Great. So most of these MCQs, guys, I've actually based it on Harrison. I've kept it as simple as possible. I didn't want to go further than Harrison because I think most of the my target audience is preparing for NEET SS. But for those who do want to prepare for NESS neurology, you can contact me. I'm there on Instagram, and I can send you some materials. And also, I've also made a question bank for Surgtest, and my notes I've also put it on Surgtest. So most of my content is actually based on Bradley, Harrison, Adam, and Victor. So those who are specifically preparing for NESS neurology or who want to know a little more about it, you can talk to Surgtest, the concerned admin people. So the Q bank and notes is there on the Surgtest app. And you can also, if you want to have any personal queries, you can text me on Instagram. So great, guys. We'll close this poll. So most of you have got it right. I think very brilliant crowd. So the answer is actually RRMS. Yeah, so the answer is RRMS. So RRMS is actually 90% of all MS is actually RRMS, and 10% of MS is PPMS. So we'll just go into the types. So this is a very very illustrative graph that is given in Harrison. So here this is relapsing remitting MS. So basically what happens is the patient has frequent relapses in neurological symptoms, but in the intervening time, the patient is neurologically quiescent or normal. But however, in the true sense, this is not true. And Harrison also has highlighted that in this diagram, because eventually over time, the patient actually does develop some sort of interictal disabilities. Okay, so initially maybe RRMS, the other than the periods of the acute relapse or attacks, the patient might be normal, but eventually over time, they actually do accrue very subtle neurological deficits. And very important, remember that 1 to 2%. Okay, so it's a little controversial percentage. I think earlier it was 3%, but now it's around 1 to 2%. So 1 to 2% of RRMS patients will convert into SPMS. That is a secondary progressive MS. So secondary progressive MS is just like RRMS. It has relapses and it has relapses and remissions. But after the relapses and during the period of remissions, the patient slowly accrues neurological deficits. So RRMS will have only attacks. In between, they will be normal. But in SPMS, secondary progressive MS, they will have relapses. But in addition to the relapses, they will have worsening neurological symptoms. And then we have PPMS, a very interesting one and sometimes very difficult to diagnose actually. So this is 10% of all MS cases. The patient does not have any relapses at all. Okay, so they're not going to present to you acutely with a myelitis or an optic neuritis, but over time, slowly, they slowly acquire focal neurological deficits. So it is primary progressive. So these are the three types. Please remember, important facts here is the most common one is RRMS. PPMS is 10%, and 1 to 2% of RRMS will convert annually into a secondary progressive MS. Okay, guys, we'll go to question number 20. So we have 10 more questions after this. So which of the following is false regarding primary progressive MS? We'll keep the chat box open. I'm very sorry that I have not finished within an hour. I think I should time myself in the next class. Okay, but anyway, we'll complete this. Okay, little tough question. It's taken from a very short excerpt in Harrison. It's also a very important demographic factual question. Okay, now most of you are answering it right, but only 6 have answered, 7, 8. Please, more of you should try. Okay, so I guess this is the tough question. There is a lot of competition between option B and option C. So I'll end the poll right now and we'll analyze this MCQ. But I'm very happy that all of you tried. So which of the following is the false option? Okay, so let's analyze this. So already we know this 10% of MS is because of PPMS. So this option is correct. Early age of onset compared to RRMS. Okay, so actually this is the answer. This is the false statement. So actually if you take RRMS, usually the age of onset is around 20 to 40 years. But when you take primary progressive MS, when you take PPMS, primary progressive MS, the age of onset is a little older. Okay, it's around 40 years, just like in NMOSD. And very, very important, even sex distribution. Sorry, it's not that. This is actually true. I mean, it's a true fact. So if you take RRMS, male patients, if you take RRMS, female patients are more involved than male patients. But if you take primary progressive MS, more or less this sex distribution is even. Okay, so these 2 points, don't forget, later age of onset and a more even sex distribution. And yes, as per McDonald's criteria, the patient should have 1 year of disease progression. The patient should have 1 year of disease progression to diagnose as PPMS. So these are the important facts. Let's rush through them. So 10% of cases, sex distribution is more even. That is, males and females are more or less equally involved. In contrast to RRMS, where females are more commonly involved. And the onset is later in life, very, very important, at 40 years. And it is a very disabling illness, okay, compared to SPMS as well as RRMS. PPMS is very, very disabling. Okay, the patient is going to be having very high EDSS scores and is very likely to be wheelchair bound very early into the illness. So this is the McDonald's criteria for PPMS. I'll be discussing another MCQ about the actual McDonald's criteria. So remember, this 1 year is a very important possible MCQ. So patient should have 1 year of disease progression, either retrospectively or prospectively. Plus, the patient should have 2 of the following. So number 1 is evidence for dissemination in space. Okay, the patient should have evidence for dissemination in space based on 1 or more T2 hyperintense lesions in the MS classical regions. So what are the MS classical regions? This is also an important MCQ. Periventricular, juxtacortical, infratentorial, as well as the spinal cord also, that they have mentioned separately here, evidence for dissemination in space in the spinal cord. So actually Harrison's has not updated this and has not updated this, unfortunately. So like I mentioned, there are 4 classical areas for MS. So one is periventricular. This most of you know it. One is periventricular. Next one is juxtacortical. Okay. So the important addition that is made in the 2017 revision of McDonald's criteria, not only juxtacortical, but even cortical lesions is taken as an MS classical site. So please don't forget this. It is not mentioned in Harrison. Okay. So both juxtacortical as well as cortical lesions is taken for dissemination in space. It is an MS classical area. And then third one is infratentorial. So this is mainly cerebellum and the brainstem. Infratentorial. And the fourth one is the spinal cord. So like you have the 6 core characteristics in NMOSD, these are the 4 important areas that are involved in MS: periventricular, juxtacortical, infratentorial, and spinal cord. Please don't forget, it's not given in Harrison. That's why I've added it. Cortical lesions are also added into the MS classical areas in the 2017 revision of McDonald's. And for this PPMS, don't forget this 1 year. Okay, so PPMS, this is the McDonald's criteria. Don't forget 1 year plus 2 out of 3 of this. And the third and most important one, positive CSF oligoclonal bands. Okay, so we will come to this oligoclonal bands and the importance in McDonald's criteria in another MCQ. Okay, so very easy MCQ, factual MCQ. We'll rush through it fast. Only 30 seconds, guys. Okay. So which of the following vitamin deficiencies is associated with multiple sclerosis? Very easy one. I'm sure most of you are going to get it right. Okay, we'll conclude, guys. Most of you have answered the right option as expected. So the answer is vitamin D. The answer is vitamin D. So vitamin D deficiency is associated with multiple sclerosis. And this is probably the reason why multiple sclerosis is very common in the Scandinavian countries and areas more in the Western hemisphere where sunlight exposure and vitamin D and is very, very common. So what are the risk factors for MS? So you guys can try in the chat box till I finish typing it. So one is vitamin D deficiency, as we mentioned. Number 2 is genetic. Okay. So genetic will be the next MCQ, which HLA is very important. Next is Epstein-Barr virus infection, but Epstein-Barr infections which are acquired after early childhood, okay, not the ones that are acquired during childhood. So basically, adult EBV infections is a risk factor for multiple sclerosis. Anything else? The last one, anyone wants to try? Yeah, Sayaj, I see your answer on HLA. There's an update in the 21st edition, which I'll come to. Yeah, great, Priyanka. The answer is smoking. So these are the proven risk factors. Okay, so these are the proven risk factors for multiple sclerosis: vitamin D deficiency, genetic, which will be coming to, and Epstein-Barr virus infections that are acquired after early childhood or in adulthood, and also cigarette smoking. So don't forget this very, very important fact. So question number 22. So which of the following predisposes to multiple sclerosis? So guys, this is a update from 21st edition of Harrison. I think 20th patient, most of you who have read the 20th edition might differ, but this is just an update. They've given a more specific HLA. That's all. It's not that it's an update, but so I'm sure most of you know that HLA B1502 is not the answer. So anyone in the chat box can tell me what is the importance of HLA B1502 in neurology. It's very, very important HLA in neurology. We test it very, very often in the epilepsy clinic, at least where I am doing my residency. Okay, so we'll stop this poll. Okay, so stop the poll. So the answer is HLA DR15. So let's go into this. It's a fact. It's basically a factual question. So HLA 1502. Anyone wants to answer in the chat box? Anyone wants to answer in the chat box? 2 minutes time. Okay, fine. So just remember HLA DR15, and actually HLA DR15 contributes to 10% of the this one. 10% of the disease risk. So looking at the chat box. Okay. So HLA B1502. So maybe you guys can get back to me after the class. What's the importance of HLA B1502 in neurology? Okay, but the answer over here is actually HLA DR15. You can refer the Harrison 21st edition. It's mentioned there. So let's go to the next MCQ. So 7 more. Okay, so long stem MCQ alert. Okay, so you review your patient who was a 36-year-old female patient who was recently diagnosed with multiple sclerosis, and she has a fraternal twin. Okay, so she has a non-identical twin who is a brother and accompanies her during this consultation, and he seems to be pretty concerned regarding his risk of developing multiple sclerosis in the future. So what would you tell him regarding his risk of developing multiple sclerosis in the future? And these are the questions. This is a frequently asked question, especially for those who are attending EDSS. So actually, I've come across this scenario in real life. So actually, I had 2 identical twins who had presented with multiple sclerosis, but however, both of them had presented at different points of time. But however, both had presented with transverse myelitis. Both of them doing well. They're actually on fingolimod. So, but this question is not identical twins. This question is fraternal twins, that is non-identical twins. Okay, I'll keep the chat box open for another 10 seconds. Sorry, I keep the poll open for another 10 seconds. Okay, so Sehaj as usual has got the answer right. Great, okay. So we'll end the poll. More 50% and plus have got it right. So the answer is 1 in 15. So 1 in 13 is actually for identical twins. That is almost, that is 33%. Okay, so this I've actually seen both patients, identical twins, presenting with multiple sclerosis. So it's not that it doesn't happen. We've seen it. 1 in 15 is for fraternal twins. Okay, it's for non-identical twins. And 1 in 50, this will come to. Maybe I'll keep a tabular column. It'll be easier for you guys. So 1 in 3 is for identical twins. 1 in 15, that is in our MCQ, is for fraternal twins or non-identical twins. 1 in 25 is for any other normal sibling. Okay, and 1 in 50 is for half siblings. Okay, is for half siblings as well as parents. Whereas first cousin is 1 in 1,000, and the normal risk is 1 in 1,000. So just remember this. Okay, important, frequently asked question. It's there in Harrison. Please revise it. It's a totally factual question. Either you remember it or you don't. So those preparing for NESS, this is an important MCQ. So long stem question alert. So please pay attention. Okay. Right. Okay. So question number 24. So a 24-year-old female patient has presented to you with a right-sided optic neuritis, and you have treated her with a course of steroids, after which she has improved. And on examination, you note that there is a right-sided visual acuity of 6/9, that it is decreased, and there is a grade 1 RAPD in the right eye. And however, you do a detailed neurological exam, and you find out that she's having some spasticity over the left lower limb with the left-sided extensor plantar. So which of the following is needed to diagnose this case as multiple sclerosis based on the McDonald's criteria? Okay. So basically you have a patient who was presented with we'll come to the options. I just want to, we'll put it in the next page. Okay. So you have a patient who was presented with one clinical attack. Okay. You have a patient who was presented with one clinical attack. Patient has presented with one clinical attack, that is an optic neuritis. She has no history of any previous clinical attacks, but however, you have objective evidence. Of two lesions. Okay, you have objective evidence of two lesions. That is, you have a right-sided RAPD and you also have a left lower limb spasticity. So, which of the following is needed to diagnose this patient as multiple sclerosis at this juncture? So, little difficult MCQ. We'll see how many get it right. We'll come back to this MCQ after discussing the McDonald's criteria, so we can answer it again then. Okay, only 10 have answered, please. More of you need to try. Okay, guys, we'll conclude. It's a difficult MCQ, I agree. So we need to work on this. We'll spend a little time on this MCQ. Okay. So for that, we'll go into McDonald's criteria. So McDonald's criteria 2017 revised. This is the table given in Harrison. There are a few changes to it, which I will tell you. So now let's say the patient is having two or more attacks. Okay, the patient is having two or more attacks. Let's say the patient is having an optic neuritis and he's having a myelitis. Okay, so he's having two or more attacks, and there is objective clinical evidence for two or more lesions. Okay, so you have clinical evidence of two or more lesions. So what is this evidence? Okay, so this evidence can either be clinical. So clinical evidence could be something like an RAPD or a spasticity or an extensor plantar or an area of sensory loss. So you basically have history of two attacks. So the patient has a history of optic neuritis and history of and transverse myelitis, but that is not enough. You need to objectively provide the clinical evidence for this. Okay, and if you have two or more attacks with objective clinical evidence of two or more lesions, you can straight away diagnose the patient as multiple sclerosis. In the true sense, you actually don't need an MRI, even though that's not what we will actually do in the real sense. But in the true sense, if you have two or more attacks with objective evidence, clinical evidence of two or more lesions, yes, patient is diagnosed with multiple sclerosis. So objective evidence can be provided by clinical features. So a basic clinical exam is important, and evoked potentials. Okay, so evoked potentials is very, very important. So VEP, somatosensory evoked potentials. Okay, so VEP is visually evoked potentials. So this is the importance of evoked potentials in a patient with multiple sclerosis. So let's say the patient has an optic neuritis and a myelitis. Okay, and you check the patient, and however your clinical examination of the optic nerve clinically is normal, but for myelitis you are having some sort of clinical evidence in the form of spasticity or some upgoing plantars, but you don't have any proof for the optic neuritis. The fundus is normal. So in this scenario, doing a VEP is important. So VEP will show prolonged P100 latency. Okay, I'm not going to the details of this. Okay, those who are preparing for NESS can go into this, but just remember VEP will show prolonged P100 latency. So this gives us a new objective clinical evidence. Okay, so this is how you have to acquire it. So two or more attacks with objective clinical evidence of two or more lesions, yes, diagnosed. Now let's say the patient has two or more attacks, but has only objective evidence of one lesion, but with a reasonable historical evidence of a prior attack. Okay, the patient should have a reasonable historical evidence of a prior attack. That time you can diagnose the patient as multiple sclerosis. So let's go to the other scenario. So let's say you have a patient who has two or more attacks. Okay, but you have only objective clinical evidence of one lesion. So let's say the example again, patient has an optic neuritis, so that's one attack, and patient is having a myelitis. So you do have two or more attacks, but you have only objective clinical evidence for one. So let's say you just have a prolonged VEP, but you have no evidence for this myelitis. Okay, so in this scenario, you have to establish dissemination in space. So in patients with two or more attacks, with only one lesion where you have an objective clinical evidence, you need to establish dissemination in space. So how do you establish dissemination in space? You should have one or more T2 lesions in the MRI in 2 out of the 4 MS typical areas. So I've already told you what are the 4 typical MS areas. It is periventricular, juxtacortical, and cortical. Okay, remember in Harrison they have not mentioned it, but it is there in the 2017 revision. So both juxtacortical and cortical involvement, infratemporal and spinal cord. So in these 4 areas, you should have at least 2 areas should be involved with 1 or more T2 hyperintense lesions in the MRI. So either you could do this, or you could wait for another clinical attack. Okay, so this is how you establish dissemination in space. So this is for this scenario. Now let's go to scenario number 3, and this is the scenario for our patient. So the patient is having only one attack. Okay, the patient is first time presenting to you with only one attack, but you have clinical evidence of 2 or more lesions. Okay, so basically, let's say the patient is present to you. Let's take our case. Okay, so she's presenting to us with optic neuritis. Okay, so she is present to us only with optic neuritis, only one attack. But on a clinical exam, she is having an RAPD and a decreased visual acuity in the affected eye, and she's also having some UMN signs in the left lower limb. So she is having objective evidence of 2 or more lesions. Okay, so in this scenario, you need to demonstrate dissemination in time. Okay, guys, this takes some time. I recommend after this class, you go back to Harrison and go through the tabular column. It takes some time to understand McDonald's criteria. For some reason, it's very difficult. And only after entering DM residency around 6 months, I was able to get the hang of this. So anyways, this is our case. Okay, so basically one attack with objective clinical evidence of 2 or more. So how do you prove dissemination in time? Okay, so the simultaneous presence of both gadolinium enhancing and non-enhancing lesions, which are asymptomatic. Okay, so simultaneous presence of asymptomatic, both enhancing and non-enhancing lesions in the MRI, number 1. Or number 2, if you already have a baseline MRI and this patient is presenting this time with a new T2 hyperintense or contrast enhancing lesion, irrespective of its timing, this is also taken as evidence of dissemination in time. And what is not mentioned in Harrison and very important is CSF oligoclonal blast. So most of you must be wondering, why the hell do we do the CSF OCBs? What is the use? It's not to diagnose MS, but actually CSF OCBs is actually dissemination in time. Okay, CSF OCBs positivity is a proxy for dissemination in time. So how do you demonstrate dissemination in space? I've already told you, in these 4 areas, at least 2 areas should be involved. And for dissemination in time, if you have a baseline MRI, and in this attack, the patient is having a new lesion, that is dissemination in time. If the patient is having asymptomatic, both enhancing as well as non-enhancing lesions in the MRI, that is also dissemination in time. And very important, presence of CSF oligoclonal blast positivity is dissemination in time. This is based on the 2017 revision. For some reason, it's not mentioned in Harrison. I'm not sure why, but it doesn't mean it's not there. So please don't forget, CSF OCBs is equal to dissemination in time. So let's go to another scenario. So the patient has only one attack, okay, and you have objective clinical evidence of only one lesion. So let's say the patient has only optic neuritis, and objective evidence, you're only having some, let's say VEP is prolonged. Okay, let's take VEP is prolonged. P100 latency is prolonged. So you have one attack and objective evidence for only one lesion. And this is what is known as a clinically isolated syndrome, CIS. Okay, EDSS people, don't forget, CIS is very important. One clinical attack with one objective evidence. Okay, so let's say an optic neuritis is only with a prolonged VEP. So in this scenario, you need to demonstrate both dissemination in space as well as dissemination in time. Okay, so you need a DIT plus a DIS. I'm not going to repeat again. All of you know what is dissemination in time, and all of you know what is dissemination in space. So I'm not going to go into that. Okay, so that's a large MCQ. I think let's rush through the last 5 MCQs very soon. So which of the following correctly describes black holes in MRI and multiple sclerosis? Please open the polls. Okay. More of you need to answer, please. Okay, many are getting it wrong. I don't know why. So it's a rank deciding MCQ probably. Okay, I'm going to stop the poll anytime now. Okay, so most of you have actually ticked B. Okay, I'm not sure why, but just remember, black holes is nothing but in T2 weighted MRI, it will appear hyper intense. Most of the demyelinating lesions actually for that factor hyper intense on T2 weighted MRI, but on T2 weighted MRI, it will be hypo intense. Okay, but always remember, in an acute demyelination, all acute demyelinations will be T2 hyperintense and T1 hypointense. So this actually black hole should be analyzed in a patient who is neurologically quiescent, like not in an acute attack. So in those patients, when you take an MRI, if there is T2 hyperintensity with a T1 hypointense lesion, that is what is known as a black hole, and black hole means irreversible damage. Okay, it's usually a poor radiological marker. So it is T2 hyperintense, T1 hypointense, and it is a marker of irreversible demyelination and axonal loss. Okay, it's a fact. It is a marker of irreversible demyelination and axonal loss. And like I told you, it depends on the timing of image acquisition. There's no point of commenting on a black hole in an acute demyelination. All acute demyelinations will be T2 hyper and T1 hypo. But in a patient who is not an acute attack, if you take an MRI, and if you see many of the T2 hyperintense lesions on the MRI are actually T1 hyperintense, that is not good. That is a black hole, and it's a radiological marker for a guarded neurological prognosis. So question 26, Paka factual question. So which of the following formulas correctly describes the CSF IgG index? Okay, guys, purely factual question. So I want you guys to again, guys, I'm just repeating again. These are actually somewhat basic. It's based on Harrison. For those who want a more detailed reading in neurology, or those who are preparing for the Central Institute exams, you can probably subscribe to the QBank. I've made, I think, around 1,400 MCQs for neurology based on Harrison and Bradley, and also my notes. So I think around 120 plus notes. I don't know whether it'll be I wouldn't recommend you to go through all of it for NEET. So NEET, just stick to medicine. For those for NESS, it will surely be useful. Okay, we'll conclude, guys. So I'll write down the formula. Okay. So first we'll go through what Harrison is given. So CSF IgG index is actually the ratio of IgG to albumin, the CSF divided by the same ratio in serum. So complicated words, let's make it simple. So basically CSF IgG divided by CSF albumin into serum albumin divided by serum IgG. Basically just inverted, guys. So CSF IgG index. So that's what you're looking for now. So first what you do is you put CSF IgG divided by CSF albumin, and then you just multiply it into the inversion of the serum. That is serum albumin divided by serum IgG. So what's the answer? Yes. So it is CSF. That's what it is. I think because of this a little complicated. So it's CSF IgG into serum albumin. Yes. Divided by CSF albumin into serum IgG. Yes, CSF. Okay, so factual question. Okay, so chat box. So to those who are active in the chat box, frequently asked question. So what is this sign? So can you tell me what is the sequence? I want you guys to tell me both the MRI sequence as well as what is the sign. Very, very frequently asked MCQ, not only in NEET SS, but also NEET PG. And I think it was first asked in November 2011 AIMS. That's the first time when they brought up this MCQ. AIMS PG, not SS. Yeah, so like I said, all of you are very, very well acquainted to this radiological sign, but I want you guys to tell me what is the sequence. Anyone wants to try? So that's more important, especially for those prospective neurology residents. So say I just put as, yeah, Sapna got it right. It is T2 flare. Okay, great. So T2 flare, what view? Sagittal. Okay, great, Sandhya. So sagittal. Great. Okay, so this is a T2 flare, MRI brain. Okay, always go for MRI brain. And this is a sagittal cut. And this sign is seen only in the sagittal view. So that's why I wanted to ask you what is the sign. So this is basically periventricular. You can see these finger-like projections, T2 flare hyperintense finger-like projections. So this is known as, oops, sorry. So this is known as Dawson's fingers. Okay, so this is known as Dawson's fingers. Very, very frequently asked question, not only for NEET SS, for NEET PG also. So you can't afford to get it wrong. So that's why I put it. And the reason for this Dawson's fingers, so nice to know, actually it is because of the perivenular. Okay, so you have these medullary veins in this orientation, which are radially oriented. So for some reason, most likely because of the fact that the immune cells are actually near the blood vessels. So because of this perivenular demyelination, and these vessels or veins are actually oriented radially. If you take the perimedullary veins, are actually oriented radially. So around these veins, you have this demyelination. Okay, so that is the reason why you get Dawson's fingers. Just a nice fact to know. That's it. So question number 28, again, factual question, guys. So which of the following is false regarding pregnancy and multiple sclerosis? Please open the polls. So overall disease course is unaffected, more attacks in the first trimester, less attacks in the third trimester, and more attacks in the postpartum period. Purely factual question. It's an all or none phenomenon. Either you know it or don't. So if you don't, it's okay. I'll tell you right now. Most of you are getting it right. Remember, the question is what is false, not what is true. Okay, guys, we'll conclude since most of you have got it right. Okay, so let's analyze this MCQ. So we'll go from down to bottom. Okay, the reason I'm going down to bottom is because A is actually the answer. Okay, so more attacks in the postpartum period. Yes, this is the correct answer. Less attacks in the third trimester. Less attacks in the third trimester. Yes, this is the correct option. Overall disease course is unaffected. Yes. So if you take the pregnancy as a whole, including the postpartum period, so even though there are less attacks in the third trimester and more in the postpartum, this evens it out. So overall the disease course is unaffected. More attacks in the first trimester is a false. Okay, so this is the answer. It is not such. It is not like that. There are no more attacks in the first trimester. There are just less attacks in the third trimester, but there are more attacks are in the postpartum period. But overall, disease course is unaffected. So course of MS in pregnancy, third trimester, more attacks. Postpartum, sorry, my bad, mistake. Third trimester, there is less attacks. Postpartum period, there is more attacks. But overall, it's the same. All right, so we'll go to the next MCQ. So question number 29. So what is the Kurtz's EDSS usually in patients with progressive multiple sclerosis? So EDSS is basically a scoring system that helps us to understand the disability of our patients with multiple sclerosis. It's a very important scoring tool for most of the trials, the drug trials that are done for multiple sclerosis. So it's very important for us too. It is an MCQ. Okay, so I think 31% have given it wrong. For some reason, 62% have given the answer as B. Okay, so the answer is actually not B. The answer is actually 4. Okay, so an EDSS of more than 4 is usually seen in the progressive varieties of multiple sclerosis. This is taken verbatim from Harrison. So your SPMS, that is secondary progressive MS, as well as PPMS, primary progressive MS, both generally tend to be neurologically doing much bad than their RRMS counterparts, and usually they have an EDSS score of more than 4. So the Kurtz's EDSS is a widely used measure for the neurological impairment in MS, and usually the RRMS patients will have a score of less than 3.5, and usually these patients are ambulant. Okay, they can walk normally without any sort of support. But in contrast, in patients who have EDSS scores of more than 4, so this is an important point in the EDSS. So more than 4, usually the patients are significantly gait impaired, they're occupationally impaired, usually need support, some sort of crutches or sticks or wheelchair to ambulate. And this is usually seen in the progressive varieties of MS, that is SPMS as well as PPMS. So I just wanted to show you the EDSS. Okay, so you can't, it's very difficult to by heart it. So just remember that 0 is normal neurological status and 10 is actually death due to MS. Okay, 10 is death due to MS. And here we can see the cutoff at 4. Okay, so usually see at 3.5 EDSS, the patient is fully ambulatory, but only with moderate disability in one of the functional scales. But however, once the patient reaches the EDSS of 4, the patient needs support to walk. Okay, so that this 4 cutoff is very important. Usually less than 4, relapsing remitting MS, somewhat neurologically better. More 4 and above, they're usually significantly neurologically impaired, especially in ambulation. So how do we calculate this EDSS? Again, I'm not going into the details. It is out of scope from this class. So just remember what are the different domains that are assessed in the functional status score for putting EDSS. So one is pyramidal functions, cerebral functions, brainstem functions, sensory functions, bowel and bladder functions, visual functions, and very, very important, we tend to neglect is cerebral or mental functions. So most of us have the norm that multiple sclerosis patients usually just have some weakness, optic neuritis, have some bowel and bladder issues. But actually that's not true. Many of the multiple sclerosis patients have cognitive issues and sometimes are significantly cognitively challenged. That's also very important. It's not that MS spares the cognition. Okay, that's a very common feature in MS. So I conclude the class with this. So I think I've covered most of the important topics. Okay, so it's very difficult to cover entire multiple sclerosis in one class. It's a very vast topic, but I just wanted to touch upon the important things like McDonald's criteria, the 2007 update, and OCB positivity for dissemination in time, and presence of cortical and juxtacortical lesions, and the other important facts. So we'll conclude. We'll cover treatment of multiple sclerosis. It's a very huge topic. Okay, it's not possible to cover it in one class. So probably I'll gel the multiple sclerosis treatment with one of the other classes. So if you guys want to get back to me, or if you have any other doubts, or any of you want to pursue neurology as a career, who are prospective neurology residents, you can follow me on Instagram. I will try my best to personally address your doubts or whatever. And yeah, and I also need your feedback for the class so I can improve. So it's very important to keep improving. And I think I'll stop. And with this, it means a lot. Okay, thanks.